Hand numbness and tingling is a very common problem. If the hand numbness and tingling is in just one of your hands, then there are 5 most common causes, and we're going to talk about each of them as well as how to treat each one in a moment. If the hand numbness and tingling is in both of your hands, then there's a 6th cause that we'll discuss as well. And finally, there's an exciting diagnostic twist at the end with critical therapeutic implications that we'll be sure to cover because it's often missed, but it's tremendously important to not miss, whether you're a patient or whether you're a doctor. I think they call that a teaser, but regardless of what they call it, you don't want to miss it. Hello, I'm Dr. Grant Cooper at Princeton Spine Joint Center. When you think of diagnosing and then treating whatever is causing your hand numbness and tingling, the first question that you should always ask yourself is where exactly in the hand are the symptoms located? If the numbness and tingling is confined to the first 3 fingers, these guys, and the inside of the 4th finger, then that's in the distribution of the median nerve. The median nerve is the nerve that's inflamed and compressed in the carpal tunnel in Carpal Tunnel Syndrome. Now, you've probably heard of Carpal Tunnel Syndrome. Indeed, Carpal Tunnel Syndrome is the most common peripheral nerve entrapment in the entire body, and it's the most common cause of numbness and tingling in the hand in this distribution. Carpal Tunnel Syndrome symptoms are often worse in the morning when you first wake up, or sometimes the symptoms will actually wake you up in the middle of the night. This is because when you go to sleep, you may have your arms and your hands straight, and when you wake up, they may be straight again. But in the middle of the night, the human reflex is to go like this. And when you do that, you end up compressing the nerve as it runs through the tunnel. Here's the tunnel, and then here's the nerve underneath it, and it runs like this. So all night, the nerve is usually getting irritated by the position of your wrists. This is why one of the first steps of treating carpal tunnel syndrome is to wear a brace at night to prevent your wrist from flexing like this. Here's the tunnel, the carpal tunnel, and here's the median nerve coming through the tunnel. Sometimes bracing for carpal tunnel syndrome isn't enough to fix the problem. But don't worry, there are other good treatment options that are available. So physical therapy is one conservative measure that can be very helpful in conjunction with bracing. Now, physical therapy will focus on stretching the wrist, strengthening the wrist and the hands, and using soft tissue mobilization and nerve glides to help decrease the swelling and increase mobilization in and around the wrist. If bracing the wrist at night doesn't take away the problem, then wearing the brace during the day as well will allow the nerve to rest even more. Here's the tunnel, the carpal tunnel, and here's the median nerve coming through the tunnel. Sometimes bracing for carpal tunnel syndrome isn't enough to fix the problem. But don't worry, there are other good treatment options that are available. So physical therapy is one conservative measure that can be very helpful in conjunction with bracing. Now, physical therapy will focus on stretching the wrist, strengthening the wrist and the hands, and using soft tissue mobilization and nerve glides to help decrease the swelling and increase mobilization in and around the wrist. This is an ultrasound machine, and this is an ultrasound probe. An ultrasound-guided steroid injection is sometimes used to treat moderate or severe carpal tunnel syndrome. Now, the injection reduces the swelling and the inflammation in the carpal tunnel, which takes the pressure off of the median nerve. But it's important that if you use an injection to take away the inflammation, that you also use bracing in order to address the biomechanics after the injection has alleviated the inflammation and the swelling. Now finally, it's rare, but sometimes surgery is needed to decompress the carpal tunnel in order to release the pressure on the median nerve in the tunnel. Now this is called a carpal tunnel release, and it can be done endoscopically, meaning with a tiny camera attached to a surgical device to see inside the tunnel, or with an open incision. Now, endoscopic surgery typically results in less pain and less recovery time than open surgeries do, but there are pros and cons of each approach depending on the situation. Additionally, some surgeons will now use ultrasound guidance to guide a minimally invasive surgical approach. If the numbness and tingling is in the outside of the fourth finger and in the fifth finger, then this is in the distribution of the ulnar nerve. The ulnar nerve is the second most common peripheral nerve that gets entrapped in the upper extremity. Now, the ulnar nerve can be entrapped in two different points in the arm. The most common place for the ulnar nerve to be entrapped is actually in the elbow. When you hit your funny bone and you feel those weird shock-like feelings in your elbow and in your forearm, well, there isn't a bone that's particularly funny in your elbow or anywhere else. What you're actually hitting is your ulnar nerve as it wraps around your elbow over here. For the same reason that carpal tunnel syndrome often has worse symptoms in the morning, cubital tunnel syndrome does too. This is because, like we said before, at night you may start sleeping like this, but at some point in the middle of the night, your arms go like this. And this puts extra stress on the ulnar nerve as it wraps around the elbow. So one of the first ways to treat cubital tunnel syndrome is to put like a neoprene sleeve on your elbow in order to keep your body from fully flexing the elbow at night. This keeps the pressure off of the ulnar nerve as it wraps around the elbow. Cubital tunnel syndrome risk factors include arthritis in the elbow, recent trauma to the elbow, swelling in and around the elbow joint, or most commonly activities that involve repetitive pulling, reaching or lifting, or maybe the most common of all, where you're constantly putting pressure on your nerve by leaning on your elbow. So, the first step of treating cubital tunnel syndrome, in addition to using a neoprene elbow sleeve at night, is to address any biomechanics during the day that might be contributing to compression of the nerve at the elbow. For example, to stop leaning on your elbow. Additionally, if you use a computer, make sure your seat isn't too low. If your seat is too low, then you may be leaning on your elbows without even thinking about it. Also, make sure you aren't leaning your elbows on your armrests. Look, to the extent that you have to have your elbows on hard surfaces, then getting a soft elbow pad to cushion the elbow is a good idea. Topical anti-inflammatory medications such as Voltaren gel, which you can think of as like a topical Advil, may also be helpful. Physical therapy that focuses on nerve gliding exercises is also helpful for a lot of people. Injections have a much more limited role for cubital tunnel syndrome than they do for carpal tunnel syndrome, but some doctors still use them and some doctors still report good benefit from it. But the evidence in the literature for this purpose is pretty sparse. Surgical decompression for cubital tunnel syndrome can be performed in severe cases. Now, there are three potential types of surgeries that can be done for cubital tunnel syndrome. A cubital tunnel release is a simple decompression of the tunnel in which the ligament roof of the tunnel is cut and divided. This works best if the nerve does not slide out from behind the medial epicondyle of the elbow when the elbow is flexed. Another surgical option is called an ulnar nerve transposition surgery, in which the ulnar nerve, this green guy, is moved from behind a bone in the elbow to in front of it. Now, this is called an anterior transposition of the ulnar nerve. And finally, a medial epicondylectomy is another surgical option in which the medial epicondyle in the elbow is partially removed. And this in turn takes the pressure off the nerve and keeps the nerve from becoming impinged when the elbow is fully flexed. But the ulnar nerve can also be compressed at a second location. Guyon's canal is the name given to the space where the ulnar nerve enters the hand over here. Guyon's canal syndrome is the third most common peripheral nerve entrapment in the upper extremity. So look, if there are symptoms in the elbow and in the forearm, as well as ulnar nerve symptoms in the outside of the fourth and the fifth fingers, then the ulnar nerve is most likely entrapped at the elbow. On the other hand, if the only symptoms are in the ulnar nerve distribution in the hand and fingers, then it still could be cubital tunnel syndrome, and by the numbers it's more likely, but it could also be Guyon's canal syndrome. Of course, it's important to differentiate between Guyon's Canal Syndrome and Cubital Tunnel Syndrome because the treatment is going to be very different. Risk factors for Guyon's Canal Syndrome would be a recent trauma to the wrist or to the palm, or repetitive microtrauma where force is repetitively put through the palm, such as with cyclists from their hands pushing on the handlebars. Now, ganglion cysts are also one of the most common causes of Guyon Canal Syndrome from direct pressure from the cyst onto the nerve. Treatment for Guyon's Canal Syndrome starts with seeing if you can address the biomechanics that led to the syndrome in the first place. A cyclist might be able to adjust his or her posture on the bike in order to alleviate some of the pressure off of the wrist. A neutral wrist brace worn at night to prevent hyperflexion of the wrist, as well as wearing that brace during the day, and particularly during any difficult activities, can be quite helpful as well. Repetitive hand movements and strong grasping should be minimized as much as possible. So for example, if you can avoid doing carpentry, or avoid doing plumbing for a while. But look, if you can't avoid those activities that seem to aggravate your symptoms because it's your job, you can't take time off, or whatever the reason, then try to wear a brace during those activities. Now, topical anti-inflammatories such as Voltaren gel can be helpful. Physical therapy with special attention to nerve glides, stretching, and strengthening the hand and wrist muscles can also be helpful. An ultrasound-guided steroid injection can be helpful to take away the inflammation and the swelling in the canal. However, again, if a steroid injection is performed, then it's important to remember to follow it for at least a week or two with bracing and relative rest to allow the nerve to heal afterwards. Finally, surgery to decompress the nerve in Guyon's Canal Syndrome can also be performed. Now, if the numbness and tingling symptoms are in only one or maybe two fingers, and if the numbness and tingling symptoms are associated with neck pain and or arm pain, then the numbness and tingling in the fingers may be coming from irritation of the nerve roots in your neck. If the numbness and tingling is confined to the thumb and maybe the inside of the second finger, then if it's coming from the neck, it's most likely coming from the C6 nerve root. The middle finger would be the C7 nerve root, and the outside of the fourth and the fifth fingers are more commonly coming from the C8 nerve root if they're coming from the nerve roots in the neck. If there are no neck or upper arm symptoms, the nerve roots exiting the spine in the neck can still be causing the numbness and tingling, but it does become less likely. Now, one way that you can also check things out for yourself is to do the following. If your right hand is the hand with the numbness and the tingling, then turn your head to the right and look over your right shoulder. Now, if doing this either hurts your neck in here, or if it increases the symptoms in your hand, then this argues that the neck is likely to be involved. And this is because when you look to the side of the symptoms, you're actually closing the holes where the nerve roots are exiting your spine. And if those nerve roots are already inflamed, then this will irritate them and cause a temporary increase in symptoms. I wanted to show you what was going on with the neck when you turn your head to the right by taking out one of my models. So this is a cervical spine model. The brain would be up here. This is the front. This is the back. The yellow things over here are the nerve roots, and they're coming out of the holes over here called the foramina. When you turn your head to the right, what you're doing is you're turning it like this and you're closing the holes where the nerves are exiting the spine. So if those nerves are already irritated and inflamed, then as you make that hole smaller by looking to the right, you are irritating those nerve roots and recreating some of the symptoms that you were already having, or maybe irritating the neck too, just temporarily. Inflammation in the nerve roots in the neck, which is medically referred to as a cervical radiculopathy, or a lot of people will just say a pinched nerve in the neck, however you want to call it. When the nerve roots in the neck are inflamed, they're usually successfully treated without surgery, and that's important to keep in mind. First-line treatment generally includes some form of physical therapy or prescribed exercises with special attention to postural exercises and getting your head back over your neck instead of sticking out your head in front of your neck. Your head basically weighs as much as a bowling ball. So all day your neck is holding up essentially a bowling ball on top of itself. Now imagine holding up a bowling ball on top of your head with your arm. That would be really hard, but now imagine holding it in front of your head with your arm. That's a lot harder. Well, we're doing that with our necks all day because most of us, a lot of us anyway, instead of sitting like this, we tend to be like that, right? Our head comes forward in front of our neck. And that's a lot harder for the neck to hold up. So a lot of physical therapy and therapeutic exercises is getting the head back over the neck because it's a lot easier for the neck to support the head if the head is positioned over the neck. And so a lot of the therapeutic exercises are geared towards getting the muscles to want to fall into this better postural position in order to help support the neck to support the head, right? Because if we can get that head back over the neck, it's going to be a lot easier ask of the neck to do the job of holding up the head without getting injured. It's also important to take a look at your biomechanics during the day. It's particularly worth looking at your relationship with your computer, since that's such a common problem these days. If you have a laptop, realize that laptops are inherently hard on your neck and posture in general because the screen and the keyboard are attached to each other the way that they are. But what you can do to help fix that problem is to get a Bluetooth keyboard so that you can place the computer monitor up, ideally at eye level. You should have your shoulders relaxed and your elbows at 90 degrees while you type away happily on your detached Bluetooth keyboard. Now you can buy our Princeton Spine Joint Center Bluetooth keyboard for just $19.99 here on our no, I'm just kidding. I'm sorry. That was that was a terrible joke. We aren't selling anything, but you can find Bluetooth keyboards just about anywhere, including Amazon or wherever people buy keyboards. Another helpful hint is to take your computer monitor from your desktop and move it closer to your face. So that way, if you start to slouch forward, you would bump your nose into the screen, and that reminds you to sit back straight again. Now, my screen is fixed here, so I'm out of luck. But ideally, I would take this screen and I would put it here. I'd have my shoulders down, my elbows at 90 degrees, and the screen would be here. So that way, if I start to get lazy, I bump into the screen, and it reminds me to sit back up. If symptoms aren't getting better with exercises and improved posture and better ergonomics, sometimes an epidural steroid injection is used to alleviate the inflammation around the inflamed nerve root. Now, when this is done, if and when an epidural is successful and the inflammation and the swelling are alleviated and the symptoms are therefore mostly resolved, it's important to think of the injection as not the whole treatment, but rather as a window of opportunity during which you can now focus on your exercises, focus on your posture in order to improve the biomechanics so that as the steroids wear off, which they will, the inflammation doesn't return. Basically, the steroids address the inflammation that's causing the symptoms, but they don't address the biomechanics. So the exercises and the posture is what addresses the biomechanics. Acupuncture and gentle chiropractic care are also sometimes used to treat pinched nerves in the neck. And sometimes surgery is needed because there's just too much compression and stenosis around the nerve. When surgery is performed, there are two basic surgical approaches. There's a decompression surgery in which the bone and the disc and anything else that's compressing the nerve is removed. You can think of this as sort of like a rotor-rooter for the nerve. Now, this is a relatively small surgery as spine surgeries go. There's a recovery time of approximately 2 or 3 months. The other type of surgery is a decompression and a fusion surgery in which the nerve is decompressed, but the bones are then also fused together, typically with hardware. Now, this is a much, much bigger surgery and is performed if the surgeon is worried that a decompression surgery alone might destabilize the whole spinal structure. Destabilizing the spine would, of course, be very dangerous. And so if that's even a possibility, the surgeon can't take that risk. And so in those cases, a fusion also has to be performed. Now, this typically is more likely in patients with a lot of accompanying arthritis at multiple levels. This type of surgery is much more involved with longer operating times and longer recovery times. The recovery can take as long as 6 to 12 months, as well as additional concerns that more pressure may be slowly placed on the other parts of the spine after the surgery is done, leading to potential adjacent level disease years later. Now, obviously, surgery is a very serious decision, and there are lots of important variables that need to be considered with your family and your doctor if surgery is being considered at all. Finally, if you have numbness and tingling in the top of the thumb, or in the first finger, or in what we would call the anatomical snuff box over here, or in the back of your hand, you may have wristwatch syndrome. Well, I like to call it wristwatch syndrome, and so do a lot of other doctors, but the real medical name is Wartenberg Syndrome, also known as superficial radial nerve palsy, also known as Cheiralgia paresthetica. It's not the most common problem, but it has gathered an outside number of names for itself. The radial nerve comes down the back of your arm and into the forearm, and then a superficial branch of the radial nerve branches off, and it comes very close to the surface of the skin as it passes into the wrist and the hand. A tight-fitting wristwatch or recent handcuff use can compress and irritate the nerve. Another common cause of Wartenberg syndrome is from a stretch injury to the nerve, such as during a fracture fixation surgery or from a forearm fracture itself. Now, repetitive twisting motions of the wrist, such as using a wrench all day, can rarely, but it can, cause this syndrome as well. Usually, Wartenberg syndrome can be healed by removing the offending problem and allowing the radial nerve to rest. Now, this can be done by taking off your watch if your watch is causing the syndrome. It could be healed by not being arrested again if you had on handcuffs that were too tight. If repetitive wrist twisting is causing the syndrome, then ideally you could stop using your wrist in that way, or if you can't stop it, then you could wear a neutral wrist splint to support the wrist while using it. A topical anti-inflammatory like Voltaren gel can also be helpful. And in rare instances, if symptoms are persistent and they're not improving with rest, bracing, Voltaren gel, then physical therapy might be helpful as well as potentially a steroid injection. In even rarer cases, surgery can be used to decompress the radial nerve, although it's very unusual to need surgery for Wartenberg syndrome. Now, if the hand numbness and tingling occur in both hands, then it's still possible that you have one of these peripheral nerve problems, for example, Carpal Tunnel Syndrome or Cubital Tunnel Syndrome or a pinched nerve in your neck. And it just happens to be that it's happening in both arms. But having symptoms in both upper extremities also raises the possibility that you may be getting these symptoms from what we would call a peripheral neuropathy. You can think of a peripheral neuropathy as sort of like wear and tear in the nerves. It can be caused by a lot of different problems, and I do mean a lot. It can be caused by diabetes, which is the most common identifiable cause. It could be caused by infections like Lyme disease or syphilis. It can be caused by a host of medications as well. It can also be caused by vitamin deficiencies like deficiencies in folate or B1, B6, B12. It can even be caused by too much vitamin B6. And half the time, when someone has a peripheral neuropathy, we don't even find out what is causing it. A peripheral neuropathy is a generalized problem of the nerves. Now, typically, peripheral neuropathy symptoms will start in the feet because those are the longest nerves and therefore they're the most vulnerable to systemic problems in the nerves. But sometimes a peripheral neuropathy will present first with symptoms in the hands. Note that if you've been having numbness and tingling in the feet and now you're also starting to get numbness and tingling symmetrically in the hands, then this is going to make the diagnosis of peripheral neuropathy much more likely. Usually, peripheral neuropathies are not going to be better or worse with different movements. This is because peripheral neuropathies aren't mechanical. So they aren't worse when you're typing or sewing, or when you wake up or go to sleep or bicycle or go rowing. Usually, though to be fair, not always, the symptoms of numbness and tingling are more or less constant, and they don't get particularly better or worse with activity or rest. Now, remember, this is in sharp distinction from peripheral nerve problems or from nerve irritations in the neck. Treating peripheral neuropathies starts with trying to identify an underlying cause for the neuropathy. So, if you have an infection causing the neuropathy, then treat the infection. If it's a side effect of the medication, ideally you could use a different medication without that side effect. If you have a vitamin deficiency, then you could replace the deficiency. If you have a diabetic neuropathy, then the first step is to gain better control of the sugars. About 3/4 of the time, unfortunately, an underlying cause cannot be treated. In fact, in half of the cases, we don't get to identify the underlying cause. We can't figure that out. In all of these instances, instead of fixing the cause of the neuropathy, we're left treating the symptoms. Now, the two most common types of treatments are supplements and medications. The most effective supplements would include alpha-lipoic acid, but first make sure you aren't vitamin B1 deficient, because if you are deficient in vitamin B1, which is also called thiamine, then taking alpha-lipoic acid might be toxic for you. Now, N-acetylcysteine has been used with some efficacy for neuropathy symptoms, particularly for diabetic neuropathies. Curcumin and omega-3 fatty acids are good general anti-inflammatories, and some people report improvement of their neuropathy symptoms as well. Now, a lot of people take vitamin B supplements for numbness and tingling symptoms. But if you don't have a deficiency, then these are unlikely to be very helpful. And you do want to be careful because, as we mentioned, too much vitamin B6 can actually cause a neuropathy. Now, the most common prescription medications for neuropathy symptoms are Neurontin, also called gabapentin, and Lyrica, also called pregabalin. These are nerve membrane stabilizing agents that work better on nerve pain and burning than they do on numbness, and they're rather hit or miss on symptoms like tingling. The major drawback of these medications is that they can affect your mood, they can make you tired, they can make you dizzy, they can give you memory issues, particularly in older people, but anyone can have these side effects. Now, other common medications would include tricyclic antidepressants like amitriptyline, and there's another medication called duloxetine, which is also called Cymbalta, which is a selective serotonin and norepinephrine reuptake inhibitor that increases these chemicals in your body. Now, none of these medications fix a neuropathy, but they're all intended to treat the symptoms of a neuropathy. They all tend to work better on pain and burning and less well on other symptoms. They all have their own side effect profiles, so of course, talk to your doctor about the pros and cons of each of these medications before starting one. And finally, we have to discuss the diagnostic twist that we teased in the beginning. As they say, it may be last, but it's definitely not least. This diagnostic information is really, really important, and it's so important in large part because it's often overlooked by patients and sometimes, and I hate to say it, but it sometimes gets overlooked by doctors as well. I'm talking about something called double crush syndrome. Yes, double crush syndrome is the medical name, and as you will see, it's also a very descriptive term of what the problem actually is. Double crush syndrome is when a nerve is irritated or compressed at two different locations along its course. Now, because the nerve is compressed at two different spots, the symptoms are amplified. You can think of double crush syndrome as similar to a river that's blocked at two different points, and so at the end of the river, the water is running very slowly. If you want the water to run fast again, you really have to unblock it at both of those 2 points. A lot of times, I've seen patients who'd been diagnosed with carpal tunnel syndrome, and they ultimately had carpal tunnel surgery, only to realize that a large percentage of their symptoms were actually coming from the cervical spine. And so the carpal tunnel surgery only helped a little bit, and the patients were really frustrated as a result. Now, what basically happened in most of these unfortunate cases is the doctor who the patient first saw found the carpal tunnel syndrome, which was there, and they immediately went about treating it conservatively. But when the symptoms didn't get better, the doctor never stopped to consider that something else might be going on, but instead they just assumed that this was just a difficult case of carpal tunnel syndrome, so the doctor went on and performed surgery. Only to find out that the worst part of the problem was actually coming from the C7 nerve root. So what happened was the C7 nerve root was inflamed, and then the branches off the C7, it goes off and it branches a few times, and it feeds the median nerve, which was also compressed as it ran through the carpal tunnel. The carpal tunnel then underwent surgery, which took away only a small part of the problem, but not enough of it, leading to a rightfully very unhappy patient who was then coming to me for a fresh medical opinion. So it's really, really important to make sure you have the full diagnostic picture before you start treatment, and particularly before you consider surgery. Someone with a peripheral neuropathy might also have Cubital Tunnel Syndrome. Someone with a pinched nerve in the neck might also have Guyon's Canal Syndrome, and so on and so forth. The gold standard way for doctors to evaluate the peripheral nerves is with something called an electrodiagnostic test. It's also called an EMG. Now, this is an EMG machine. We use it to essentially trace the nerves out and see where the nerve problem is and if there's any nerve damage going on. My wife, who's also a doctor, and we trained together in New York, but she was first a biomedical engineer. She likes to describe an EMG as that it's like the symptoms are a light bulb, and the nerve test is tracing the wires that go to the light bulb to see where the problem in the wire or in the wires is. It's important that when doing an EMG that the whole nerve is traced out. Once in a while, a doctor will find one nerve problem and not think to continue testing the other nerves to make sure that he or she isn't missing a double crush syndrome, like in the case of the carpal tunnel patient I described earlier. So for all my colleagues out there, let this be a reminder to all of us to never be complacent with our diagnostics, and remember to always check the full length of the nerve, including the nerve roots exiting the spine. I had a mentor who liked to say, "Semper in custodia." Let's all stay vigilant and conscientious in our diagnostics. Thank you very much for joining me in my office this time. Usually I record these videos at home, but I wanted to try something new and use some of the models here. I hope you enjoyed this video on hand numbness and tingling. If you did, I would invite you to both click the like button and help us to continue to grow by subscribing to our channel and telling at least 50 or 60 of your closest friends about us as well. Just kidding. Thank you again. As always, if you have any questions or comments about this topic, and if you have any requests for future topics, then please leave me a note or a question in the comments section below. I wish you all the best of health.